hopefully you'll kind of start to understand a little bit more. And even as a parent, I would always kind of, there is a part that we'll talk about in here, and I would always be like, why are you doing this? It's very common for them to resort back, and we'll talk about that. And that was kind of my thought as a parent is, well, what is wrong with you? Okay? So some developmental characteristics or considerations. Growth and development vary considerably between, birth and adulthood. Go figure, right? The first year is a super active year for these kids because they're learning and they're developing at a very fast rate of speed. Okay, so some classifications that are going to help you determine. So, how does the kiddo behave? Okay, how do I overall approach this kid? Because your approach is going to be different, oftentimes based simply on the age and the maturity level of the child or developmental level of the child, and then your physical assessment approach also. Okay, kids who are frightened or in pain or sick typically act younger than their age. That's what I was talking about. So my 13-year-old will still hang on me. When he doesn't feel good, I am the first one to know he doesn't feel good. He stands as tall as I am. He weighs almost 150 pounds. He's like, I'm a linebacker, and the high school said I was stacked, right? So he's thinking he's pretty hot stuff till he's sick. When he's sick, he literally hangs on me. He boy, you've got to get off me. You are too big for this stuff now. What is wrong with you? Well, that's why. Okay? So let's talk about some classifications. Technically, newborns are from 0 or birth to 28 days. So most of the time we'll generally kind of go about a month. Okay? Infants are from that 28 days, 1 month time frame to a year. Toddlers, 1 to 3. Preschool is 3 to 6. Now I realize most of us start school at 5. Just remember, for medical purposes, they're considered preschool through the age of 6. Okay? And then school ages 6 to 12, adolescents between 12 and 18. Now that's a huge gap. Look at that, 12 to 18 years old. So think of what you were like when you were 12, or if you have a 12-year-old, okay? Now think of what you were like at 18. Okay? Those children, because let's be honest, they are children, still fall into that adolescent category, and sometimes those are going to present some challenges on their own. So they have a wide range of maturity level, don't they? Well, we hope. Okay? So keep this in mind. Newborns. Birth defects, of course, and unintentional injury are typically the leading cause of morbidity. Okay? Why is it unintentional injuries when they're newborn?
Because they can't injure themselves?
They're talking about non-accidental trauma. They're talking about child abuse is not.
Child abuse is unintentional, that's what you're saying?
No. So, okay, I dropped the baby. Somebody was holding the baby and they dropped. That's unintentional injury. Non-accidental trauma is not unintentional injury.
So child abuse
doesn't fall into this category. Why are they not likely candidates typically for child abuse? There's some caveats to that, but babies are low maintenance when they're this young.
Yeah, they sleep.
Exactly. Okay? So sleeping babies when they're a month old are very common. Okay? So they're at that lower risk category because, again, you can lay them down and they're, aside from changing a diaper and feeding a bottle, you don't have to do anything. Okay? Are you with me? Look around. They're going to try to focus on faces. They don't have coordinated movements. Okay, so typically when they're trying to do stuff, or when they're doing stuff, it's not really intentional and it's kind of uncoordinated. They don't have, they kind of look like that, not like a seizure, but, okay. And then their behavior, they're going to have minimal stranger anxiety. All right, because while they say actually, the last bit of information I read said, babies recognize mother's voice at birth and dad's within 14 days. They can differentiate that. Now, I think some of that's going to depend on the involvement of dad during the pregnancy, too. You know what I mean? So that contributes to that minimal stranger anxiety. They just don't know. Assessment techniques, typically, it doesn't matter. right? They can't kind of respond one way or another based on you. It's just, they're just kind of there, all right? Interactions, they definitely like to be held. They need to be kept warm. These guys can't regulate their body temperature well, so we need to keep that in mind as we're going through and assessing them, okay? Make sure you try to warm your hands and your equipment before you come in contact. So that means just rubbing on your stethoscope. Give it a little bit of friction and heat it up a little bit, okay? Keep them wrapped in blankets. Be very cautious of loud noises because they're going to still startle, okay? And even bright lights, they're going to kind of squint and they're not going to be real cooperative there, okay? Infants, this is, remember that about 1 month or 28 days to 1 year old, all right? They're normally alert and looking around. Now, this is going to be a wide range of kids, okay? Their eyes will follow the examiner, how they can straighten their arms and legs. These are averages, so this can sit unattended. 6 to 8 months is an average, okay? Not uncommon for babies to do it early, and some of them are going to do it later. What's equally important for us to know as EMS providers is what's normal for the child. You know, like they can't set up today, but they've been setting up for 3 months. Okay, we might be a little concerned about that. You see kind of what I mean by that? So it's good to know, are they developmentally delayed or not? But, well, he won't set up. Well, how old is he? Well, he's 8 months. Has he been setting up? Or 6 months? Has he been setting up? Has he been doing this or that? Okay? And then their behavior, they definitely will get separation anxiety, and they'll start having a fear of strangers. Now, this is going to develop at different times for various kids. Okay? Rachel, when did your kiddo start developing stranger anxiety? Do you know? Do you remember?
I don't know about my son, so I was telling but my daughter, she started getting it around like 6 months.
6 months is pretty typical. Delaney's going on 8 months, and now, as long as she's with mom, she knows no stranger. She smiles, she cues, she'll play with you. The minute you try to hold her, it's done. She just wants mom.
When they took her to a woman checked her 1 year checkup,
Mhm.
doctor, we were like literally prying her off in order to get her to sit down and take a look.
Absolutely. So one of the things you need to understand about this separation anxiety and the fear of strangers is, if you can assess them on mom's lap, you're probably going to want to do that. We're going to learn a little bit more about that when we start getting into pediatric assessment. But there are absolutely times, and I'll tell you, EMS is really leaning towards this family-centered care. Okay? So there are times it's appropriate and it's okay to involve the parents and let them continue to hold the babies. Okay?
Is it worse with one gender or another?
No. It's all based on the kid.
Okay.
You know what I mean? Assessment technique. So for this infant, you're going to perform most of your assessment before approaching or while you approach. So most of your assessment for actually a lot of pediatrics are going to be done at this distance as I'm walking up to my child. Okay? And we're going to learn all about this. Again, allow them to sit in the parent's lap because of that stranger anxiety. All right? And then assess feet to head unless they're critically ill. And we're going to talk, you're going to learn about that pediatric assessment triangle that I do from here to Mickey as I'm approaching. And that's going to kind of dictate or drive my assessment. Luckily, okay, most of the time when we go out on these kids, they're not critically ill. Okay? Thank goodness, right?
Are they more like old people? I know in the sense of people grabbing stuff, they didn't like showing signs of old people, but they're hiding stuff, not feeling pain.
Yeah, well,
Or they-
no, they feel pain. Now, their neurological system is still kind of developing. Huh? Babies. So that's why they're uncoordinated. They're still trying to develop. So when you start talking about newborns, then they start to develop that coordination. And they're when they start developing control of their body, so like those neuro stuff, it starts head and it goes to feet. So you'll see they have control of their head long before they intentionally have control of their arms.
Well, I'm asking, it's easy. Is it easy to assess a baby because they're not pretty much obvious? If you even squirming around, or they're going to
Well, it kind of depends. Okay, well, it depends on a lot of things. So it depends on their developmental stage. Because they may be difficult or they may kind of be willing to let you do whatever. So it's going to depend on the developmental stage and how sick they are, quite honestly. No, but they feel pain. Babies feel pain. The problem is it's referred pain. So a lot of babies, when they have, for example, an ear infection, they will not pull at their ear. They will not indicate to you it's an ear infection. They'll just cry because they don't understand where it's coming from. They feel the pain, but they don't know kind of where it goes or where it's from. Now, when they get older, they can kind of pull at their ear or play with their ear. That might be an indication. Does that make sense? But they don't have the mental development to kind of understand where it came from to give you those clues. Right. Yeah. Again, they do like to be held. Distract them with a toy or pen light. And, you know, they like those bright lights by about this age, right? What do we have on our mobiles? Bright lights. Toys that light up or play music. Okay, those are what's going to get their attention. Toddlers, remember this is 1 to 3, okay? And then they're normally alert, very active. This says they can walk by 18 months. It is not uncommon. And, you know, I was really surprised. My husband and our oldest daughter were walking at 7 months, which is really young, okay? But typically it's about a year. By 18 months, most all of them should be walking, okay? They do not like to sit still. If you have ever had a niece, nephew, cousin, whatever, they don't like to sit still. You can only hold them for a little bit of time, okay? And they're going to start grabbing at some of your stuff, and they're going to push you away, right? They typically don't like to be touched because, again, you're having to hold them still. You may be able to, hey, give me a high five kind of thing, right? These guys won't like being separated from their parents, especially with a stranger, and they're very well aware of it, okay? They have a different kind of acknowledgement. And then fear of pain and needles, absolutely. You're going to find that this fear of pain and needles develops early, and it hangs around for a long time, okay? Some of us are still scared of pain and needles, all right? So how are we going to do this? Again, allow them to sit in their lap. Make a game of the assessment, all right? Distract them again with the toy or pen light. Go from toes to head. Luckily, most of the time we can do this, okay? And then allow the parents to participate in the exam. When would I not want my parents to participate in an exam?
If they're making it worse?
Yeah. Kids feed off their parents, and they feed off them significantly. So if the mom is like freaking out, okay, we got to calm mom down, okay? They don't like having their clothes removed, so make sure, and this goes with your little babies too. I know some of them run naked. Some of them want to be in their diaper, and that's okay. Remember, though, so remove the clothing, examine. So lift up the shirt, listen to breath sounds, kind of look at the chest here. Now cover them back up, because remember, especially on the babies, warmth is key. Okay? Sometimes it's going to be difficult to hear through those blankets, especially because they have such little air volume, right? It's going to be difficult to hear, and they're hyperresonant across their chest. So you can hear upper airway sounds, like if they have a stuffy nose or snotty nose, you can hear that down in their lung sounds if you don't know the difference. Yep, you got to listen in the bases, kind of underneath the armpits. Yep. Make sure that they know they're not bad, okay? That this is not a punishment. How many of you have been in a restaurant or in a doctor's office or anywhere? And I've seen this both as an MP, as an EMS provider. The kid will be acting up. We'll be sitting there on duty, right, eating our dinner. And the parents go, if you don't be good, I'm going to tell them to give you a shot.
They do that.
They do that a lot. If you don't sit down, I'm going to tell the police and they're going to take you to jail, right? So they make us the bad guy in advance. They assume and associate us with punishment, with pain, with all of this kind of stuff. So you need to make sure that they understand this isn't because you were bad, it's okay, you know, kind of stuff. We already have a battle ahead of us, okay? And these guys might not like that mask. They, you know, like if they have to have an oxygen mask, they probably won't like it. So what are some of the things that we can do? Okay. What else?
Have mama put it on her face and then...
They still won't. They don't. It's the being on the face. Okay, maybe let them hold it. How about draw a little face on it? Hey, do you want to be a lion? Look, let's put the nose and draw some whiskers, right? You can do that very quickly with Sharpie. Most of us in EMS will have a Sharpie. So, I mean, there are things that we can do. Luckily, luckily, if they're pushing it off their face, you kind of go, well, how much do they really need it? Because they're cognitive and they're aware and this kind of stuff. Although they can still be very agitated and be having oxygen issues, right? And agitation increases our oxygen consumption. It raises our metabolism. Therefore, we burn more oxygen, need more oxygen. Okay? Keep that in mind. Kids have very high metabolisms. Okay. So preschool, this is at 3 to 6. Okay? Alert and active. Most of them can sit still on request. Okay? Most of them. If you get a request for them to sit still, most of your assessment's kind of done, right? Pretty easy. They can usually cooperate with the exam. They understand speech or talk. Okay? Here's the thing. These guys will make up things that they don't understand. So if I'm taking a 3 to 6-year-old, 5, 6, whatever, they have to go have a tonsillectomy. When the parent says, look, they're going to go back here, they're going to knock you out, then they're going to, you're going to go to sleep, and then they're going to take these tonsils out, and you're going to wake up, and this is how it's going to go, right? What do you think that kid thinks they're going to do? They're thinking the Tom and Jerry, the big hammer, bonk on the head kind of stuff, right? They make up what we don't tell them. So you need to tell them, look, you're going to get some bubble gum, some air that smells like bubble gum, because they use some stuff like this, right? Make sure you know before you tell them. Don't misguide them, okay? But anesthesia has all kinds of things that they can do, right? They pick scents and put them in the mask so they smell them, and then they kind of go to sleep, and then they start their IV so they don't even have to do it while they're awake, and there's all kinds of stuff, okay, that they can do there. They don't like to be touched. They don't like being separated from their parents. They are afraid of blood. And if you've ever had a child, you know what I'm talking about. They go and they fall down and they scrape their knee or their hand or their elbow, right? How old are your kids, Sean?
4.
Okay, so you have one old enough in this category. So, and this was always the case. I'd be like, I remember one time Eric fell, plop. Well, what are you doing? I fell down. Well, I know you fell down. Why are you still on the ground? Get up. So he gets up and he does fine until, oh my God, right? Or pulling a kid's tooth. Same thing. They see blood and they associate that with this, oh my God, this god-awful thing just happened, right? So we may have to use some distracting techniques. This is why they have, these guys kind of have a magical thinking. A Band-Aid fixes a lot of stuff at this age. Cover it up. And then they are proud of their Band-Aid. They don't see the blood. Typically they're okay. All right? They're also going to have a fear of pain, and here it's not so much needles. It is. If you say needles, they're going to go, oh my God, a shot. But permanent injury. Okay? At this age, they're starting to see kids that are different, people that are different. Right? If you've never been anywhere with a 5 or 6-year-old and they see a child that's different or somebody in a wheelchair or a person missing, they have no understand. They go, look, Mom, what's wrong with his arms? Be quiet, child. Okay? So they are starting to recognize what's normal, what's not normal. So they do start getting scared of this permanent injury. Is it going to be like this forever? So they have a broken arm, and it's obviously broken. They think, this is how my arm is going to look forever.
My sister had a cast put on, and just because she had a cast on for the normal amount of time, and they took it off, one arm was smaller than the other because just from the cast.
Mm-hmm.
I think for the next 2 months, we literally fought. We've been told, "Oh my God, I'm deformed."
It's huge.
I'm not normal.
How old was she?
She was 7 or 8. She's past the preschool age. She was.
Well, you're going to find that when we start getting into school-age kids, this is going to be a lot the same. All right. So what are we going to do for assessments? Explain what you're doing. Use those simple words. Don't use big words. Don't use medical words, okay? Tell them what's going to happen next. I don't give them very much. So I control when I tell them what's going to happen next, right? I don't tell them I'm going to start an IV on them till I'm ready to poke. Because they get anxious. They start having all this time to think about what's happening next, right? I take my kids to the doctor now. One of the things they want to know is it time for shots? If I tell them yes, they can focus on nothing but those shots, and they get themselves anxious and worked up. Okay? So be careful about how far in advance you tell them stuff. Okay? And then distract them with a story. I like to get the story, right? A lot of these times these kids did something and, hey, what happened? I fell. My God, how did you do that, right? So now, not only am I interviewing the child, I'm getting information about the history so I can kind of rule out non-accidental trauma or not, right? Kind of what happened, what the mental status, and I'm developing this rapport. This is important when it comes to dealing with kids as much as it is adults. Don't think you don't need to develop this rapport or this trust with them, because you absolutely do. Cooperation is important. Okay? Respect their modesty. Some of them will be very modest and want to be covered. This is really going to be the case for girls who hit puberty and pre-puberty stages. Again, what is this age? Right? And what is school age? 6 to 12. A lot of those girls are falling into that, starting their period at school age type stuff. Okay? They don't like having their clothes removed, so again, remove it, examine it, replace it. Because depending on if they're in school or not, they may be starting to get educated on the bad touching. Okay? So be very well aware that they understand what their private parts are. Okay? That's why it's important to make sure you keep them covered and you let them be modest. Okay? They don't want to be suffocated by the mask. So again, some of the same techniques. And assure them that they weren't bad. So school age, again, 6 to 12. Okay? They will cooperate if they trust you, right? What else do they learn at preschool and school age? Stranger danger, right? But what do they think a stranger is?
Someone they don't know.
Sometimes. Sometimes it was, oh, they talk to me, they're not a stranger. So it depends on, say again?
What mom and dad taught you.
It is. It is very much dependent on, and if they just tell them about strangers, there are kids that literally know no strangers because they're very friendly to everybody. Okay? They want to participate, and they do want to retain some control. So, well, I'll talk about that in a second. They're going to still be that afraid of blood, fear of pain and permanent injury. Again, I don't want to look different. Now I'm at school. School kids are harsh. They get picked on for being different. Okay, think about some of this, right? This goes all the way up into middle school. Okay, 12-year-olds are in 6th grade middle school. Actually, 7th grade. Some of them, yeah. Some of them are in 7th grade. And then fear of disfigurement. That's that I have to be the same as everybody else. I have to be normal, right? Kids want to wear the same clothes that everybody else is wearing. Because of that, I can't be different kind of stuff because they pick on the different. All right? So some assessment techniques. Again, respect their modesty. These girls are prepubescent. Some of them are going to start developing breasts in this time frame. Okay? They are very self-conscious. Be cautious. Okay? Let them make some treatment choices when possible. Now, what does that mean? That doesn't mean I, as a paramedic, go, well, I'm going to let you choose, do you want the IV or not? Okay? That's not an option. That's not something they get to participate in. What are some of the things that you can give them choices about in their care as EMTs?
What kind of Band-Aid they want?
Unfortunately, the ambulance typically doesn't, but I like your train of thought.
What kind of, like, if they need oxygen, like, what kind of motive to it? Like, the way you get it? Mask or
Well,
cannula?
that's not determined, though, by what they want. That's determined by what they need. So be very careful about going, do you want this or this? Because if they need this, that's what they need.
Yeah.
You see what I mean? So what are some of the choices?
Well, when I was on one of my ride-outs, one of the guys was talking to a kid about this age, like in the lower part of it,
Mhm.
and he was like, hey, do you like stickers? He was like, I bet when we get to the ER, we can find you a train sticker or whatever, and so he got him that kind of thing after the fact.
How about this? Brian, you know what? I need to take your blood pressure. You've probably had your blood pressure taken. It's like a big hug on your arm, right? Everybody wants a hug when they don't feel good.
They always say.
Which arm would you like? Do you want me to use your right arm or your left arm? Pulse ox. Look at this glowing light. Isn't this the coolest thing? Put it on your finger, let them see it, and go, pick a finger. What do you want? You want to try it? Which finger do you want to try it on?
Like a sticker for your finger.
Okay?
Don't give them the option to say no.
Don't give them an option to say no. Give them an option, which arm do you want? Right? Do you
Either way.
kind of see? But they feel like they have retained some control. They had a decision in this. They're going to cooperate with you. Okay? That is about them still feeling like they have an option. Because at this point, they haven't thought no is an option. They go, oh, well, she let me choose something. Right? I like her already. Okay? Again, they don't like having their clothing removed. So if you need to remove it, to examine. Now, again, be cautious. Okay? Be cautious about who's examining with you or where you're at in the environment in which you do so. Okay? So adolescents. Remember, 12 to 18-ish? Characteristics. These guys have a clear concept of future. Right? They're starting to think about what they want to be when they grow up. What's going to happen tomorrow. Okay? Again, they can make some decisions about care. Another way, here's what I can do. Hey, Eric, you're going to have a breathing treatment. Do you want to be able to hold that peace pipe, or do you just want the mask? That's still a decision. They're still getting their medication. Okay? And they can retain some control that way. They also know how they feel. Do they feel like sitting here holding this thing, or do they just want the mask? Would the mask make them uncomfortable? We can do it either way. Okay? Fear of permanent injury. Again, it's that whole, right? They're very modest. I've changed this boy's diapers, given him a bath his whole life. I knock on the door. He won't even get up out of bed until I leave the room. Okay? And then a fear of disfigurement. Again, they're always kind of wondering, is this permanent? Is this not permanent? But they have this clear thought of future. So I know it looks bad now. We're going to put a cast on. They now know in the future when they take this cast off, it'll be normal. Right? Everybody with me?
Okay.
Excellent. So how are we going to assess these guys?
Like an adult?
Not really, because they don't have the maturity level of an adult. So they may not have the same understanding. So explain the process to them like if they were an adult, but use words that they understand. Okay? If they look puzzled, go, that means da-da-da-da-da, right? You're going to have to treat them with a little bit of respect. So this is that whole, I'm not a kid anymore, but I'm not exactly an adult. I'm not grown yet. Okay? So you're going to have to treat them with respect. If you do that, they will more than likely cooperate with you, depending on what's going on. Kind of treat them as an adult, but remember, they're not going to have the same rights to make some decisions either. Okay? They may want to be assessed privately, even away from their parents. Something else that happens in this age range with little girls, most of them have probably started their period by now, but not all, pregnancy. Be very cautious about asking a 16-year-old girl if she's sexually active, if there's a possibility of pregnancy in front of her father or her brother, sometimes even her mom. Okay? Come on in. Okay. We'll be ready here in a minute. All right. Anatomical and some physiological concerns. So airway. They have a small airway, okay? And it's shaped like a cone. So things get in and they get lodged, okay? So be aware of that. Also, it can be blocked by secretions, especially little babies. Sometimes all they need is that bulb suction. You suction their nose out. Now, funny, they're not having so much respiratory distress anymore, okay? Their tongue is relatively larger than their mandible, okay? And remember, their oropharynx is smaller in comparison. So they got this big old floppy tongue, okay? So it's going to easily obstruct the airway. Be careful about hyperextending the neck. Now, we know we have to pat under the shoulders. We have to get it in a neutral position, basically where the ears kind of line up with the shoulders, right? But if you hyperextend it, it's just like bending that straw the opposite way. You can still occlude the airway, okay? Infants, they're obligate nose breathers, right? So typically they breathe through their nose without thinking about it. If a kid is an obligate nose breather and they're congested, they are going to have poor eating habits because they can't breathe while they eat. They may not be able to take their pacifier. They'll mouth breathe around the pacifier and then they'll go back to sucking on the pacifier while they're trying to breathe through their nose. Okay? Their head, proportionately larger than adults. Now, we know that a kid's head isn't the same size as mine. They're talking about proportionate to the body. the head is much bigger. So think about your bobble dolls. That's every toddler and infant you know. Okay? Say what? Yeah, kind of a pumpkin on a stick. We kind of, you've seen those people that you go, wow, their head doesn't really match their body. That's every kid. Okay? Infants cannot support their head. They start learning to support their head kind of in that, later stage. Now, even though they can hold it up, right, if it comes to a force, we can kind of help support our head. They don't have the muscle control yet, even if they have the control to hold their head up, right? Do you guys know what I'm talking about? Okay. And then they have some fontanelles, and then there's an anterior and posterior location, and they may be, so look, it's going to depend on the kid. So if you feel it and it's sunken, you need to think dehydration. If it's bulging, you need to think there's extra fluid in here, whether it's blood or CSF. Okay? Not always the case. Sometimes you can see those little ridges. You can always feel Delaney's, and it's a little bit sunken. All of my kids were, but they have a fine hydration state. So some of the things I can ask is about how many wet diapers are they making, this kind of stuff. Also, parents will notice that. They have noticed, they might not notice it's sunken today, but if you kind of go, hey, this feels a little, is this normal? They can go, you know what, I think that's lower than usual. Okay? Here's what you know about respiratory kids. They compensate well. Okay? They increase, and this even says short periods. I'm going to tell you, kids compensate well. They compensate, they compensate, they compensate, they compensate, and they keep going up, and then they hit this cliff, and they decompensate quick. They will compensate until halfway through that decompensation stage that you see in adults. You don't typically see that in kids. Okay? And we'll talk about that. They do get rapid respiratory muscle fatigue, and then general fatigue in infants. Okay? This is that head bobbing stuff that you'll see them do. This is a baby that is so tired and is expending so much energy to breathe, they can't hold their head up in between breaths. Every bit of energy and muscle, anything that they have is going towards breathing. So they'll do this. They really head bob. They are using all of those muscles. They just don't even have the energy to hold it up anymore. That is bad. Very bad. Okay? Ribs are more pliable than adults. Okay? When they say a bouncing baby boy, typically they mean it. All right? Not that they are not able to be fractured, but it takes a significant force to cause a fracture too young. All right? Their lung tissue is extremely fragile, and then minimal chest wall excursion. Greater abdominal movement. These guys belly breathe. They rely on these because they don't have the intercostal muscles that we do. So they really use all of their muscles, and even their abdomen isn't real developed. You guys have seen these kids that breathe, right? Even using their belly. Okay, they do have abdominal movement, not just with breathing, but their muscle or their organs are larger, and they're closer to the skin, closer to the surface. Also, the thing you need to understand about their ribs is you see an adult, and our xiphoid is up here, and then our ribs come down here. Children don't do that. They're much more horizontal. As they grow, it kind of stretches down. So they don't even have as much coverage over their abdominal organs as we do. Okay? They do breathe more shallow because the lungs are smaller. They have less volume, and we kind of already mentioned that earlier. Cardiovascular system. They become tachycardia. So here's what you have to understand about tachycardia in kids. It's kind of a general rule. The smaller the animal, the higher the heart rate, the lower the blood pressure. Okay? So, newborns are going to have a high heart rate, and then as they go into toddlers, or infants, they're still going to be higher than adults. And then they don't kind of get down into that normal. They're like till probably toddler school age. Okay? So when we talk tachycardia, we're not talking over 100 like in adults. We're talking over the normal ranges based on the kid's age. Because it's going to vary a lot from birth to even 3, what we would expect it to be. It's not uncommon for babies who are born to be at 140 or 160 heart rate. Okay? So, things that will make them tachycardic. Fear, of course. Fever, everybody can get tachycardic with fever. Okay? anxiety, activity, and hypovolemia. Kind of all the same things for adults, right? Just watch, because their tachycardia is higher than ours. Make sense? Bradycardia, a late response to hypoxia for children and older infants. So here, when we become hypoxic as adults, our heart rate goes up. These guys, their heart rate goes down. So now, does that make sense? Remember that inverted triangle that we talked about on Wednesday? Now, do you know why the first thing we do is oxygenate babies who have low heart rates, unless they're super, super low? Because sometimes all they need is a little bit of oxygen and their heart rate will pick right up. Okay? Smaller circulating blood volume than adults, of course. They do compensate for longer periods in general. Okay? We already talked about this. The abdominal muscles are less well developed than adults. Okay? They don't have the protective stuff, and then they're not protected by the rib cage either. All right, bones are more pliable, so you're going to see more green stick fractures. Do you guys remember what a green stick fracture is? Nope, that's a spiral fracture. It's splintered on one side, but not the other side, right? It's literally called the green stick because if you've ever been a kid or an adult out playing in the yard or picking up sticks in the yard, you pick up one that's green and you try to break it, what happens? It might break on one side, but it just bends. That is a green stick. That's why they call it a green stick fracture. Where a dead twig will snap in half pretty easily. Okay? Yeah, we already talked that the motor development occurs from head to feet, and so it's very common for them to be uncoordinated, right? Metabolic rates. They have much faster metabolic rates when they're infants and children. Again, they have a greater demand for oxygen. Whenever they're hypoxic, it's going to increase their metabolism. They're going to require more oxygen because they're going to burn what oxygen and sugar they have left. Okay? Delicate cells, like the brain, are readily damaged with minimal hypoxia. Okay? Decreased heart rate, depressed respirations, and blood loss. Bad stuff on these kids. We're going to talk about early detection. I'm wholeheartedly here to tell you, know these stuff that's going to give you your initial keys. If you wait until the obvious signs are here for decompensation in a pediatric patient, they're dead. They go into irreversible shock much, well, not really quicker. They compensate for a long time. If you wait till you see those obvious signs, you are too late. Yeah, they almost skip decompensate. It really is, it's like a cliff. So they just continue and continue and continue, and then they plummet. Okay? Skin and body surface area. Let's talk about this. Their surface area is much larger in comparison. Okay? They have a larger body surface area. So that's why when we talk about burns, it's going to pretty much come into play. Okay? And the skin, like our elderly patients, is much thinner. Okay? And more delicate. All right? So they don't develop that you've ever seen people with really tough skin? Okay? How's that going to affect them in burns? Kind of the same way it affects our adults. You think there's a reason why the really young and the really old are at high risk for some of these injuries? Okay? Or exacerbation? They have less blood, and therefore they're in greater danger of bleeding to death. Okay? They have a lower blood pressure. We kind of already talked about that, and fast heart rate, talked about that too. Their extremities are likely to appear mottled. Do you guys know what mottling is? Yeah, it's kind of like a purple marble look. Okay? You know what I'm talking about? You can see kind of it looks veiny. All right? And this is typically, and they may respond to the cold because they have that immature temperature regulation ability. They also don't have the sub-Q fat, and they have that thin skin, so it's much more difficult for them to maintain body temperature. We already talked that they're the pumpkin on the stick, so their head's a lot larger in proportion. Yep, we talked about that too. Temperature control mechanisms, immature, unstable. They have smaller airways, softer tissues. Okay, so you got to be careful not to occlude both with the tongue. Plus, they put everything in their mouth, so they're at high risk for
choking.
Yeah. They breathe faster too. Again, it's that high metabolism that they have a higher oxygen demand. Plus, they don't have the same tidal volume we do, right? So they can't get as much in one breath, so they're going to have to breathe more times so they can make the same gas exchange. Does that make sense? Cody, are you with me back there? Okay. They dehydrate easily. I'm here to tell you, if you ever go to an infant that mom says the baby's not acting right and he's had vomiting or diarrhea, done. The kid, I'm telling you, is probably dehydrated. He's probably in shock. You also need to watch their sugar. They don't have, so remember we talked that the liver does what for adults? It stores, remember the glycogen that we talked about? Those chains of sugar. So basically simple sugars kind of get together and they make this chain and it's called glycogen. So we as adults, they don't have that. That's something that you have to build up to develop. Kids don't have that. So when they start losing their sugar, they don't have as many reserves or as many compensatory things that they can rely on. Okay, so keep that in mind.
Do you just check the glucose on a baby the same way that you would an adult?
Yep, typically in the foot,
Okay.
depending on the size.
Okay. Are their rates the same?
Yep.
Okay.
Needed sugars, how would you go? Glucose is what we do, or do you want to try to them a bottle or something?
Well, so it kind of depends on why their sugar is low. So if they're vomiting, probably not going to work. Same thing, if they have airway compromise, and you're going to see that a lot. So these kids who get RSV, they can't eat. They can't drink, which is what we're really concerned about, right? Because they have this, they're so working hard on breathing, or they're so congested because of all the mucus that they can't take a bottle. Those babies need IV sugar. Okay? All right. So keys to success: opening the airway, head tilt, chin lift. Again, make sure you don't hyperextend it, and you want to get those ears kind of in line with the shoulders on those big babies with the occipital, well, kids too, with that big occipital area. And then a jaw thrust with spinal immobilization. The procedures are the same as they are for adults. Okay? See the difference here? Versus right here? You all kind of now understand what we're talking about when we start talking about padding underneath their shoulders?
So how do they sleep right then?
A lot of them don't. And they don't even allow you to put pillows in their bed because of high risk for suffocation depending on the age.
Really?
Yeah.
seems
Infants
like
don't get pillows. Infants don't get pillows or stuffed animals because of SIDS.
But that kid's old enough to not suffocate, right?
Mm-hmm.
So he could have a pillow?
Yeah.
Would that fix his head?
Depends on how he sleeps. Most of them also don't sleep on their back. All right. So, again, obstructed airway. So for infants, you're going to do back blows and chest thrusts. Try to visualize and then attempt to ventilate. Same thing, okay? You must attempt to visualize before you try to ventilate, okay? Because if I see it, it's in the airway and I can get it, and then I attempt to ventilate, I'm going to shove it right back down, and then I've been completely counterproductive. What a bad day, right? Children, make sure you do abdominal thrusts and then try to visualize and attempt to ventilate when they go unresponsive. Do not do blind finger sweeps. If you've been CPR certified for very long, we used to do blind finger sweeps and just see what we could reach. The problem is we were causing too much damage with the soft palate, and they actually, depending on the age, the hard palate isn't really formed yet, and we were pushing stuff down further in the airway, okay? So, airway adjuncts. So, your OPA and NPA indications are going to be the same. So if they have no gag reflex, you got to get the proper size. Insertion is going to be different. Because remember I said they have that soft palate and their hard palate isn't completely formed yet. So we don't start up and then rotate down because they don't have that palate for us to kind of go against. They actually go in just like they come out. You guys remember how we take them out in adults? Same thing. Yeah, so there's a couple things you can do. You can use the tongue depressor. I've not been on a truck that has them. But you can use the tongue depressor to kind of slide it in. Or I just kind of do, any fishermen in here? I kind of call it the bass, you know how you hold the bass? Kind of get a hold of that lower jaw. That's exactly how I do it. Get a hold of the tongue and the lower jaw, and especially because typically they're young enough they don't have teeth or are not going to bite me. If they need an OPA and they can bite, you probably need to redo your assessment.
Could you just do like a half turn so it's not, the tip isn't pointing towards the soft palate, so it's like to the side here?
Well, I'm...
It's not taught.
Yes. The correct procedure is... Okay. And then MPA, again, correct size. Bevel towards the septum. Lubricate with what? Water-soluble lubricant. Okay. Not for use in... You know what? I'm going to have to check on this because I don't know what the National Registry is telling you. I know that when we teach about other classes, unless they have a basilar skull fracture, an MPA is appropriate. So let me double check that and I will clarify it with you.
I read it in the book, it said no MPA for
Right, but I think there's been some updates since then. So let me check and see what the National Registry is going to test you guys on, and we'll go from there. Suctioning. Again, this can prevent air from entering the lungs. So when you suction out the snot and the goop, you're also sucking out their oxygen. You have the potential to suck out that reserve. So kind of like that dead space reserve that's full of oxygen, theirs is much smaller, so be very careful. Okay. Maximum time. Bet your book says something different, and I bet you we're going to talk about something different probably in 15 seconds. Because what is it for adults?
15 seconds.
Okay. We're going to get into that here in just a little bit. All right. Be careful of some delicate tissues, of course. Okay.
Should we correct that now?
I would just mark through it on this slideshow because I'm pretty sure you have another slideshow that addresses it.
Okay.
Okay. And then a bulb syringe. You guys know what a bulb syringe is, right? It's the blue, you squeeze it in, okay? Only suction on the way out. So that's the same thing with the bulb syringe. So if you squeeze it, right, and then you put it in the baby's nose and you let it go and it sucks out the bunch of snot, don't squeeze it again, okay? Because then you're just going to blow the snot right out of the bulb syringe back down into the baby, okay? So this is one that each time you suction, you need to kind of go onto napkin, blanket, I don't care. Squeeze it to get it out, then put it back in and suction again. Everybody with me?
Do they just throw those things out after one use?
Typically, yes.
They don't seem like they're easy to clean.
Yeah.
Garbage.
And they're pretty cheap. So typically, probably not per use. I mean, so I don't want you to think that, but per illness or as they start to get better, right? Because then you're going to just cross-contaminate the babies. Okay. Oxygen delivery. Make sure you use the appropriate sized equipment. Okay. Non-rebreathers, and then blow by. You can hold it 2 inches from the face, or you can put it in kind of the bottom of a cup or cup it in the hand, right? Because that just kind of creates that, making sure it's going in the right direction. BVM. How much air do we want to squeeze into the BVM when we're bagging a kid? No matter what size the kid is.
Half?
I just want chest rise. So once that chest rises, don't continue to squeeze the bag to give them a full breath of air. What are you going to do?
Pump their lungs.
Mm-hmm. Absolutely. Because remember, they have that delicate tissue, lung tissue. They're at high risk for barotrauma with bagging, so you got to be real careful not to do that. Again, squeeze the bag slowly and evenly. Here's what you have to understand about kids. So how often do you see a kid that's not eating something or snacking on something or has a juice cup or whatever? Their tummies are often full. Okay? 1. 2, so my trachea is kept open with these rings, right? The tracheal rings. That's why air passes easier through there. What about my esophagus? What do we know about the tube that goes to my stomach? Huh? It's kind of flaccid. It's kind of just flappy, right? So it opens and things go in. It's just kind of hanging there. All right? So if I squeeze too quickly or too forcefully or too often, where do you think that air is going to go? If I squeeze it fast, it's going to open that esophagus and let a bunch of air in.
They're going to vomit.
They are going to vomit. They're going to vomit everything up. So now you've got aspiration risk as well. The other thing I can tell you about pediatrics, remember, they rely heavily on their abdomen. You fill their tummy full of air, you are completely reducing the amount of oxygen they can get in their lungs. It is directly proportionate. So if you overinflate their tummy, they are not going to ventilate or oxygenate well. Okay? I cannot stress this enough, especially, and I'll tell you that even when we're talking about innovation with the paramedics in the sim labs, I will tell you wholeheartedly, if you have got to have the basics. You have got to be able to do this, and you've got to be able to do it very well. Okay? Okay. 12 to 20 breaths per minute. It's kind of what you're looking for, right? So what's the rate for infants? 1 breath every 3 typically. Children, here's the way I remember it. I go 3, 4, 5. Actually, I go 3, 4, 6, and I'll tell you why. It's important for you to know. So I'm going to backtrack for a second to adult respiratory stuff. For an unsecured airway, make sure you know this. An unsecured airway, so no King LT, no intubation, no nothing. It is 5 to 6 seconds. Once they have a secured airway, what is your rate? 6 to 8. 6 is kind of your magic number. You can't go wrong with 6. So that's why I kind of go 3, 4, 6. Okay? Does that make sense? You won't go wrong there. All right. So, failure to manage the airway is the preceding cause of preventable death in pediatric patients. Hands down, every time. Now, one thing else I can tell you, these guys are way more likely to have respiratory issues or compromise than they are cardiac compromise. Okay? Airways are the big deal. So, family and caregivers, they're usually not alone, okay? So require information and interact with the caregivers. Don't talk over kids based on how old they are, okay? So toddlers, school, yeah, you can probably get the scoop from mom or dad, okay? Don't talk over adolescents like they're not there, okay? Because again, now you've lost that trust that you need to have to be able to do an effective interview with them. The environment can absolutely affect the kids. We already talked about this. Calm caregivers typically are calm kids, okay? And agitated do the same thing. So they get anxiety, the parents get anxiety or caregivers from the kid's pain, the fear, okay, of what's going on with my kiddo and are they going to be okay? And then it's worsened by a sense of helplessness. Trust me when I tell you, if you have never been in a situation where you felt completely medically helpless, you have no idea. When I was home with my mom when I was 13 and she had her first stroke, I completely understand what it's like to feel helpless. We have a volunteer service that they get paid by the call. So they respond from home to the ambulance barn, and then from the ambulance barn they come to our house. It seemed like a forever wait, which kind of drove me here because I was never going to feel that helpless again. And now, as a paramedic, sometimes I still feel helpless because I don't have my tools. Okay, so, but it is a horrible feeling to feel helpless, especially when it's your loved one, especially your kid. Because moms and dads, right, they always come to us, don't they, guys? They come to us, and moms and dads are supposed to make it better. We're supposed to make them feel better and take care of them. Okay? So be understanding about that when you're on those scenes. They can display a wide range of emotions. So they can be calm and cooperative. They can be angry and combative. Some of it's going to depend on the condition, the situation, okay, what's kind of going on. And so you need to be prepared to deal with all of that. All right? Addressing the needs of the caregivers allows for more effective care. So you still have to develop a rapport with your patient because that's important. But you need to kind of develop a rapport with parents too. If the parents trust you, the kids are going to trust you. Ineffective interaction with parents, and we're going to talk about this more in non-accidental trauma or child abuse. Ineffective interactions with your parents do nothing but cause barriers for you to be able to care for the child the way that you need to do so. Okay? Please keep that in mind when you're having to deal with these angry or combative people. All right. Caregivers, they do play an important role in the treatment. Again, they can provide you some medical information, history of the events. So when we start talking later about croup or epiglottitis, okay, we need to know that. And they can provide us that good information, the history of the events. Okay? And they may even be able to help calm the kiddo. Mom, I understand that you're excited. I know what's going on. I can't imagine how you feel. But right now what I need you to do is I kind of need you to pull it together. I need you to tell him to calm down, relax, and it's going to be okay. I'm here to help y'all. You're going to have to help me help him. Right? Now they don't feel so helpless. You've kind of empowered them to be a part of this care. They see that mom is trusting you. Now, how much different is that going to be? A huge. You're right. It's huge. Okay? And then they can also tell you, again, what's normal or abnormal for their kid. Trust them. They know. I don't care why you're there. If they go, this isn't normal, and you're going, but they're acting like a normal kid. If the parent is telling you this is not normal, why is it not normal? What's different? Now what can be going on? Okay? They should really remain with your kiddo unless the child is unaware. Now, this is kind of at your discretion. As an EMS provider, it had always been my purview that if I was working a CPR or a really, really sick kid, to get the parents out of there. Sometimes the things that we do seem barbaric. They seem cold. Okay? They seem quite calculated. Okay? If they don't understand what we're doing, right? Imagine now what some of the things that we look like. I know that I've had to put an IO manually in kids, and that's where you take a big needle and you really drill it into their leg, to their bone. Okay? I couldn't imagine seeing that done to my child, even though I know what it is. Okay? So, that had always been my purview. I went to Children's Mercy, worked in the ER, and I was on the code and trauma team there. They have a very different outlook. They were more care-centered because they have a different environment. So remember, some of it's going to be, we work in an uncontrolled environment. We don't have the security a phone call away or standing out the door. But it was their purview that as long as the patient, the family members were able to maintain some sort of composure, that we let them. We let them sit in there and watch, even when we did a full CPR. Because it's important for them to understand we've done everything we can do. It's important for them to see that we've tried. Now, again, the flip side is you're going to have to seem compassionate, and sometimes part of our mechanisms for us is to detach ourselves. So that's kind of a catch-22, and you're going to have to determine what you're able to do and how you're able to effectively function and what is good for this family. Please take the family into consideration when you're determining who's going to watch me work this CPR. Okay? Again, it also gives them something to do. It empowers them. It helps them not to feel helpless. They have some control over the situation. They're going to kind of hopefully relax a little bit if you kind of explain it to them like that. Okay? They can assist. We already talked about most of this in calming the child. They can hold the baby when it's appropriate or the kiddo when it's appropriate. That's okay. And again, somebody said, I think Sean said, the parents can hold the oxygen or even apply pressure. Then they feel like they're doing something. They feel like they're being helpful, and they feel like they're there for their baby or their child. Okay? So what about us? How do we respond here? Some of it may be different for those of us who have kids versus those who do not. Okay? That's not always the case. Okay? So what do we face? What causes anxieties? Fear of failure. Now, you ever want to feel like you failed, have to go tell a parent that I'm sorry I couldn't save your kid. Okay? Lack of experience. Whether it is lack of experience with, I have never worked a pediatric CPR before. I've never put a tube in a real baby. Right? Those are very big things. Now, let's talk, Mickey, I'm not really picking on you, but kind of, right? How much experience do you have with kids in general?
Not a whole lot.
Yeah, so,
Just be- keep them with it.
right, and so you might feel a little bit more anxious than, say, Sean, because Sean's got kids, and so he kind of understands, and he knows how to deal with them a little bit better. But generally, if we don't have kids, we tend to not know as much about kind of, oh, God, this is a kid, and what do I do? Okay? Those of us who have kids could very easily recognize this could be my kid. This could have happened to my child. Right? Prime example. I took some kids to the lake for my son's birthday. We were grilling, having a good time. I am fanatical. We go to the lake because the lake has drop-offs, right? Every few minutes, I head count. I'm consciously head counting because I've got kids out there. I have some other adults helping me, right? Not a big deal. And I'm counting, and I say, stand up, because I have a rule. I don't care how good of a swimmer you think you are. You don't go out past your armpits. So if you can stand up and put your arms out like this, the water better not be over your armpits, right? One of my friends, military guy, has kids. He's kind of thinking, what's the big deal, right? He's like, Ma, you're being too strict. What is going on? Until 3 minutes later, when I got a phone call from one of the paramedics that I work with. Mind you, I had the neighbor's kids with me. They have a cousin that drowned in the pool in the backyard next to my house that they just worked the little girl. Okay. Luckily, they resuscitated her and she actually returned to baseline. Okay. That gives me chills. But as soon as I go, Rayden's cousin just drowned in his pool. They just worked him. It was everybody stand up, let me see where you're at. Okay? It is very easy for us to kind of go, either this could be my kid or they look like my kid or, I do that after. I always have, and I will probably do this for the duration of my career, I take that breakdown moment immediately following the call. I call my kids. Sometimes I don't talk to my kids. I talk to, Daddy and go, hug them tight. Tell them I love them. All right? If you have never been in this situation, it will happen. I'm telling you it will happen. It is okay to break down. It's okay to cry. It's okay to take that second. Okay? That's what we need to do to cope. But thinking that we're just going to put it away and it's not going to be an issue, I promise you it will be a very big issue for you eventually. Okay? Make sure we practice. We got to practice a lot. You got to refresh your memory a lot. Remember, I told you in the beginning, luckily, we don't go on a whole lot of really, really sick or injured kids. Thank God. But when we do, we better be on our game. So this is one of those things we don't do it a lot. We need to review it a lot more. Right? Chest pains, we could probably run those with our eyes closed because we get them all the time. Do I need to review chest pain? Maybe. Changes in my protocol, latest update of information. Pediatrics, you better be reviewing something regularly about pediatric patients. Okay? And again, separate your personal emotions from the task at hand. Sometimes that's a little bit more difficult. I can't tell you the face of any child that I've ever worked. I can tell you a lot of names. I can tell you some features, but I can't tell you what they look like in their face. However you do it, you have to put it aside until you're done. And again, that's when I have my moment. Okay? It's okay. Questions? Let's take 10-ish.